Welcome, everybody. I'm Vikas Sani, president of the Lown Institute.
I'm Shannon Brownlee. I'm former vice president of the Lown Institute and co-creator of the Lown Hospitals Index. Thank you all for joining this discussion of hospitals' community benefit.
We launched the Lown Hospitals Index last year, the first ranking that measures hospitals' social responsibility. For the second year, we're giving some individual metrics more attention. This spring, we released the results of our overuse and racial inclusivity metrics. Today, we're focusing on community benefits, and we hope you'll join us for the full launch of the entire index this early fall. You'll find the results, all of our results, including the overuse results and racial inclusivity, as well as today's, at lownhospitalsindex.org. The website also has last year's rankings, which will be updated in early fall. Now, community benefit is a major category of the hospitals index. It measures how much hospitals focus on caring for low-income patients and how much they spend on improving health in their surrounding community.
So why measure hospital community benefit spending? Because hospitals have an obligation to serve the public, and community benefit is one of the ways that they reflect their to their social mission. So we know that hospitals in that regard. So during COVID-19 surges, for example, we saw how some hospitals avoided taking patients with Medicaid or no insurance, which delayed their access to life-saving care.
We also care about how hospitals invest in community health. There's a growing understanding of factors other than medical treatment that have a profound impact on health. Too many families don't have access to safe and affordable housing, clean water, or healthy food. As a country, we are neglecting to invest in these basic needs, and as a result, we see higher rates of chronic illness like diabetes, asthma, and heart disease in underserved communities. Now, hospitals never created these conditions, but as institutions that are embedded within and part of the communities they serve, they do have an opportunity to be part of the solution. And in the absence of adequate public health policies and social spending, some hospitals have created their own food pantries, built public housing, and partnered with local organizations to vaccinate their community.
And while we didn't include it in our measurement of community benefit, the IRS also requires hospitals to report on their billing practices. Along with the IRS, communities expect their hospitals to provide financial assistance to patients who are uninsured and to serve their fair share of low-income patients. But even during COVID, some hospitals went so far as to sue patients for medical bills when the patients actually qualified for free medical care. So how do U.S. hospitals do when it comes to serving their communities? Let's bring our guests into this conversation. Sarah Rosenbaum is the Harold and Jane Hirsch Professor of Health Law and Policy at George Washington University. Professor Rosenbaum has devoted her professional career to issues of health justice, including Medicaid expansion, civil rights in healthcare, and national health reform. She's also emphasized public engagement in her professional life, providing public service to 6 presidential administrations and 15 U.S. Congresses since 1978.
And with us today also is Dr. Marty Makary, a surgeon and public policy researcher focused on the redesign of healthcare, medical appropriateness, and healthcare costs. He's the New York Times bestselling author of the book, The Price We Pay. Dr. Makary has been elected to the National Academy of Medicine and serves as editor-in-chief of MedPage Today. He's also on the faculty at Hopkins School of Medicine, School of Public Health, and their business school, the Carey School of Business. He's written for the Wall Street Journal, New York Times, and USA Today. Welcome to you both.
Yes. So charity care and other community benefits provided by hospitals are thought to be important for the health of both patients and communities. But for nonprofit hospitals, community benefit is also an IRS requirement. They're supposed to report on their community benefit spending if they want to maintain their tax-exempt status.
Nonprofit hospitals have been tax exempt since the income tax was first created in the early 1900s. But the requirements for that tax break have evolved and shifted over the years, most notably with the Affordable Care Act in 2010. So the first question, Sarah, you've studied and written about the topic of community benefit extensively. How did the community benefit requirement for hospitals come to exist? What was the original intent of the law and how has it changed?
Thank you so much for that question. Of course, you are correct that it was understood that any nonprofit entity that wanted tax exempt status had to somehow demonstrate a beneficent place in society, that it had to benefit its community. And in the early days, in the 1950s, which is really when the IRS began to formally lay out standards for nonprofit hospitals that sought tax exempt status, the IRS focused on two things. It focused on maintaining an emergency department. We had just reached the point where society, something that Dr. Makary, of course, knows far more about than I do, but where technology had advanced so far that everybody understood this critical role that emergency departments played. So hospital, to be nonprofit and tax exempt, had to maintain an emergency department that was open to everybody in the community. Number one. And number two, the hospital had to provide charity care. And the concept of charity care was not defined in extensive policy, but it was understood that you did provide reduced or free care to people unable to pay. In 1969, in a move that actually was challenged by low-income advocates, and in a case that went all the way up to the Supreme Court where it lost, the Nixon administration eliminated those two requirements in favor of a far more amorphous concept known as community benefit. That's a sort of a term of art in nonprofit law. And the Nixon administration said, you all do things that you believe in your judgment benefit the community, and we will give you tax exempt status. It was seen as a great victory for hospitals, an enormously deregulatory move, ironically. So we know this name community benefit is sort of a heralded term, and yet it was the product of major deregulation. The deregulatory phase of community benefit essentially remained as such for 40 years. It was not enforced, it was not measured. States did little with their parallel definitions. There were a few exceptions, but not much. And in the early 2000s, as the result of the leadership of Senator Chuck Grassley, who was then the chair of the Senate Finance Committee, as well as the chair of the Ways and Means Committee, the IRS was pushed and pushed and pushed to do more as the result of a series of searing reports on what were really unconscionable billing and collection practices by tax exempt hospitals. And the congressional leadership succeeded in getting the IRS, first under President Bush and later under President Obama, to rethink community benefit. And at that point, the administration, the agency developed what we now know as Schedule H. And Schedule H is in its special attachment that goes on the tax exempt hospital reporting form. And it breaks down community benefit into multiple categories. It actually gives meaning to community benefit. The biggest category being financial assistance. And we can talk about it. There's various kinds of activities that hospitals can claim as financial assistance. And then there are a series of activities known as other community benefits, which can be everything from your research activities to your health professions training programs to doing good works in the community, to like running free immunization clinics, And then, quite separate, there's a category known as community building, and I'm sure we'll talk a little bit about that. Community building is not community benefit, although under current IRS policy, hospitals can claim community benefit value for certain community building activities. Paralleling this rewrite, this regulatory revision of the concept of community benefit, the Affordable Care Act makes changes, although not in the meaning of community benefit. It skirts the meaning of community benefit. Instead, what the Affordable Care Act does is to more regulate hospital practices, requiring certain levels of transparency about the availability of financial assistance, barring unreasonable collection practices, as the term is used, and requiring community health needs assessments and the creation of what the Act calls implementation strategies, designed to give communities a somewhat bigger voice in what hospitals do in their communities. And we'll, I'm sure, come back to all these issues, but you have these two parallel activities, one being a re-regulation up to a point of community benefit, and the other being the Affordable Care Act amendments that essentially reinforce certain aspects of community benefit obligations and add this sort of new idea of the hospital as a community-wide public health actor.
That's great. Thank you, Sarah. So you wonderfully gave us a segue to talking to Marty. And Marty, I'm so glad you're here. Your team, Marty, just released a project around hospital billing practices. Now, the IRS standards also include some requirements around billing. Can you tell us a little bit about what the IRS requires regarding reporting on billing, and then how those findings compare with what the expectations might be?
Sure thing, Shannon, and good to see you again. And, thank you, Vikas, here for allowing me to share here along with Sarah, who I always consider to be one of the great thought leaders in this space. So I'm really thankful for the work of Lown, and we've incorporated that into our transparency project, the great work of Lown in measuring charity, as I'll mention here. You know, if Shannon, they're not violating the letter of the law, they're certainly violating the spirit of the law. And we can get into whether or not they're evading the regulatory requirement, which I believe they are in some cases. Now, hospitals, I've learned, are not a single entity. There's no, in all of healthcare, there's no single mindset of an insurance company, a hospital, a physician. Really what you see is a mentality that's comprised of several factors, including the local values and ethics of the leadership. And we actually have been really impressed at some of the strong leadership that some hospital leaders have shown, where they've really tried to understand their billing practices. And even when we bring what we call predatory billing to their attention, they will sometimes immediately stop those practices. And that's the good behavior the market should reward. If we cannot, you know, we'll never be able to regulate bad behavior in healthcare. And that, you know, that we should do our best to try to address egregious practices that can be regulated. But transparency does create public accountability. And so what I appreciate about the Lown Institute's Charity Care Score, and what we've also done on our team, which is really incorporating that score and other metrics around hospital pricing and billing practices, is that it's creating more public accountability. Since we released the dashboard of the top 100 US hospitals in partnership with Axios, I've gotten about 25 calls from those hospitals, some of which were outlier hospitals in their practices and some of which were not. But I would say that in all of those calls, there was a very productive tone. They wanted to understand how they were being measured, how they can improve, what they're being evaluated by. And I think that is a healthy conversation. You know, when we had surgical site infection rates and readmission rates move into the public domain, where it could be seen by not just patients that were seeking to navigate their own care, but also by external groups that were helping navigate care on behalf of patients, we saw an improvement. That public accountability did result in hospital leaders coming to doctors and saying, what do you need to do? How can we help you prevent readmissions of your patients after discharge? And we had this very healthy dialogue where there was a conversation finally about we have to give people the number they need to call if they have a problem immediately after discharge. We have to have good medication reconciliation. We have to have good follow-up visits scheduled routinely. And somebody needs to take ownership of that process. That was very productive. You know, when we had nutrition labels introduced as an idea, and Sarah will recall this public health debate that we had in the United States, many of us urging the regulators to adopt standardized nutrition labels for food, with some exceptions where it wasn't feasible, a farmer's market or something like that. But basically, we were told by the industry that this could not be done, that it would be such a regulatory burden, the cost would be so high, it would result in food price surges, and it would contribute to world hunger. We were also told that many people would lose their jobs, that there would be a job loss because of this regulatory requirement. None of that was true. None of that ended up in the final analysis being true. Instead, what we had is very healthy competition around health ingredients. And so that's essentially the spirit of the dashboard that we've tried to put out there.
Thanks, Marty. We could debate whether or not the competition around ingredients actually turned out to be healthy, since there was this sort of race to the bottom of who could have the most sugar in what they were making, when they got rid of all the fat, which is what people were most concerned about. But your point is well taken, that when you require reporting and honest reporting, you start to get a little bit of public accountability, which we agree is really important. So what I just want to sum up, though, what you said, and if I'm understanding it, is that you found real variability in billing practices, and that some hospitals were actually doing a really good job of making sure that they did their best to take care of patients who were unable to pay, and other hospitals were doing a less good job. But when it became public, there was an effort on the part of many of the hospitals that weren't doing as well to really start cleaning up their act. And do you think they really did clean up their act?
You know, for some of them, yes, and we saw a real genuine, oh my gosh, I can't believe that this has been happening. You know, some large organizations get difficult to manage. And so, you know, we assume the best in people. We take them at their word. And when they say they weren't aware and they clean it up, you know what, we'll take that result. Others kind of dug in, and some just revised their criteria, and we stayed on them and continue to ask them to stop all predatory billing. Now, There is a practice in Virginia where they are now starting to take money out of a person's income tax return through the state directly, with, you know, bypassing the individual. So there are creative ways in which some hospitals have been trying to evade the publicly reported metrics now that we have.
Yeah. And that, you know, that just requires ongoing public exposure of what's going on. Sarah, I have a question for you. What is nonprofit status actually worth to hospitals? I mean, what does this tax break actually mean to them in terms of dollars?
Yeah, it's a really good question. So in the aggregate, I have to tell you just a funny little story about this estimate. So I'm a lawyer by training. I know nothing about cost estimation. And I had, of course, read the document from a long time ago that the Joint Tax Committee wrote, basically saying that the value of the tax exemption back in 2002 was about $12.5 billion. And somebody asked me the value at that point, which was like 2014. And I said, well, it's been about 10 years. I would guess it's doubled. And people looked at me and said, you can't, you know, make up wild guesses like that. And the Robert Wood Johnson Foundation actually funded us to update the estimates using the CBO methodology and Joint Tax Committee methodology. And lo and behold, in 2011, the value was $24.6 billion. So, one can only assume that this was for 2011, one can only assume that in 2021, these things being what they are, we're probably closing in on a doubling of the tax benefit or thereabouts again at this point. So it's worth real money. I mean, as you point out, of course, in your study, if you look at specific hospitals, you can see the value of their tax exemption. And when you roll it up and look in the aggregate, it's real money to the federal government and, of course, to state and local governments. In some ways, it's more meaningful for them because of the enormous impact of property and sales tax exemptions, which can really take a bite out of the tax base of states and localities.
Yep. Yeah, thank you. So I think we have some audience questions, do we not?
Yep, we have one in particular, maybe both of you or one of you could address it, which is, do for-profit hospitals have a community benefit obligation, either in the tax code or the laws or in custom, perhaps?
Well, I can answer it legally. Legally, under the federal tax code, the answer is no. But a lot of states and localities may have various kinds of rules. I know here in DC, where I live and work, the District of Columbia still has a certificate of need law. Hospitals have to go get permission before they can undertake certain kinds of capital expenditures. And there is a community benefit expectation applicable to hospitals, including for-profit hospitals. GW's hospital used to be non-for-profit, but we are a for-profit hospital now. And so we have a community benefit obligation. So that means that as a matter of state and local law, hospitals may be held accountable. But as a matter of federal tax policy, the obligation falls on non-for-profit hospitals seeking tax-exempt status.
Got it. Well, for the Lown Index, we measured hospital community benefit based on three things: charity care spending, Medicaid revenue, and community investment activities. Now, charity care and Medicaid spending were essentially commitments to care for low-income people. And the data for these came from CMS's cost reports, which is what allowed us to compare nonprofit, publicly owned, as well as for-profit hospitals. The community investment category includes spending that has a direct health benefit for communities. Things like health education, free clinics, preventive services, contributions to community groups. And that also includes spending on social factors, the so-called social determinants that might impact health. And for this category, we use the IRS data.
So, drumroll, please. Here are the top 10 hospitals ranked by our overall community benefit metric. It should be coming up on your screen. You may notice that most of them are government-run hospitals, and that makes sense. These are hospitals that are tasked with serving everyone regardless of their ability to pay. But it's also worth noting, and we had this question just now, that much to our surprise, our number one hospital is actually a for-profit institution. So New York City also dominates the list, likely because they have a large population of Medicaid and uninsured patients, and they also have a robust public health system that's dedicated to serving these patients. They have a large system of public hospitals. So I just want to give people a chance to kind of look at this list. And then I want Sarah and Marty to kind of give us their reaction to the winners. And Marty, why don't you go ahead and give us your sort of sense? What do you think about this list?
So this is terrific, by the way. Congratulations on this work. And I think, the market should reward places that are doing what they say they're doing, and it should reward good actors. So I think this is a major step forward in transparency. We found in our work that there was sometimes no rhyme or reason. That is, it was the decision of the local leaders of that medical center that they were going to be committed to their community. And in other places, almost regardless of their for-profit or nonprofit status, whether or not they were government or non-governmental hospitals, whether or not they were in certain parts of the country that had more or less competitive markets, we did see many good actors. For example, we found, one common argument when hospitals do patients or engage in predatory billing is that they argue they have to make up money for all the charity care that they provide. Well, using the Lown charity care metric, we actually found that more of the lawsuits were heavily skewed towards hospitals that provided very little charity care. And sometimes it didn't even correlate with overall hospital revenue per bed. So anyway, I'm thrilled to see this list, and I think it's a great step forward.
Thanks, Marty. Sarah, any surprises here for you?
Yeah, but it's really dominated by public hospitals, and that goes with, it's consistent with everything that we would expect, that the public hospitals are the ones that bear the disproportionate burden of care for the uninsured, for the publicly insured. They are what we know in Medicaid policy as the deemed dish hospitals, meaning that their share of Medicaid as a total percent of revenue and of their patients is so high that they are automatically just accorded the status of what we call disproportionate share hospitals. And their whole by law, it's not just custom in their case, by law, their mission is to do what they do, and they do it under extraordinary circumstances, as you point out, from the Wall Street Journal story from California during COVID. Probably the single most searing article I read during the entire, when we were in the height of the first wave of the pandemic, was the story out of New York about what was happening at Elmhurst Hospital. What that hospital has labored under, not only because of the enormous needs of its own community, but because it became the hospital that was expected to absorb all the patients nobody else wanted. And so it's not just that they're safety net providers in their own immediate service areas. They are treated as the safety net by all other hospitals in many cases. So that, who's on this list, to me, is a reflection of that.
Yep, absolutely. Yeah, the story, we were in touch with a couple of doctors who were in a safety net hospital in Queens, and it was hair raising what they were dealing with. And meanwhile, across the river in Manhattan, it was a little more la-di-da at a lot of the nonprofit hospitals. Exactly,
and that was the story. Just a complete refusal of the the carriage trade hospitals to do what they should have done, and an expectation that whether it was Elmhurst or any of the other hospitals, that's what they were there for, and the burden was unthinkable.
Yeah. A lot of this has been going on in a sort of low key and low grade way for years. So of course, it really was COVID that just revved it up and put a real glare of a spotlight on all this, and I think made it a lot clearer to a lot more people. So we did have a lot of public hospitals at the top of our ranking, but what about the private nonprofits, the ones who get the tax exemption? And given that they get these breaks, we wanted to actually look at that question and see how many of them are giving back to their communities, and to what extent do they meet roughly what that tax exempt status gives them. So for about 2,400 nonprofit hospitals, we calculated their share of spending on charity care and community benefits. And then we compared it to an estimate of the tax burden they would have had if they were for profit. And we called that their fair share spending. And we then looked at the comparison of the community benefit spending that we measured and the fair share spending that we calculated. And what we found was that nearly 3/4 of private nonprofit hospitals spent less on charity care and community investment than the value of their tax exemption. And when you add up all that money, that came to a staggering $17 billion. So just from the point of view of what we measured and what would have been the tax benefit, that gap, so this is not what they would have paid in total, but that gap was 17 billion. And so we have a slide with the largest fair share deficits. And these hospitals, a small number out of 2,400, they make up 10% of the nation's fair share deficit. And you'll notice there's some big and well-known names that have the largest deficits. So again, Sarah, Marty, we'd like to get your reactions on this. There is something about academic medical centers that's different, and we'll get into that in a minute. But are these results surprising to you, Marty?
Not really. There's an argument, by the way, just to kind of, make it even more confusing, that because medical centers engaged in a lot of teaching, their costs may not be higher because of the teaching. They may actually be lower because residents are some of the cheapest labor in all of healthcare. I mean, I think I earned below minimum wage as a resident. And it's very hard to staff the ICU at night. I mean, that's not, a physician staffing an ICU at night, 24/7, around the clock, 365 days a year, versus sticking, 1 in 3 residents there every third night. So the argument that teaching hospitals deserve extra payment, which is an argument that maybe was true in the past, and it's an argument that is held to today in paying hospitals, that there's an adjustment for teaching, that argument may no longer be valid.
Sarah, what do you think? What's your reaction to this list, the fair share deficit list?
Again, I'm not surprised. It's the most robust, most powerful, most financially dominant in their communities. Most of them very, very high. I'm sure all of them very high reputation for the work they do. They are, as the law would say, as antitrust law would say, the must-haves in your provider networks, there are so many different ways. I mean, Marty would be the total expert on this, but in my legal practice over 45 years now, I have learned that there are so many ways that hospitals can, sometimes not so subtly, but often subtly, position themselves in a community so that, and we dealt with this all the time under the old Hill-Burton Act, of course, which essentially doesn't exist any longer, but was a precursor to much of what we're talking about today. But hospitals can position themselves so that their quote unquote doors are open, but people don't walk through them. And there are lots of reasons why they don't walk through them or they can't walk through them. So you can sort of simultaneously live in a world of beneficence and total isolation from the community around you. And I am sure, despite the good works that these hospitals do, there's far more relative to their wealth that they can do.
Well, not to be too snarky about it, but didn't Leona Helmsley say paying taxes is for little people? So everybody tries to get around paying taxes, but we kind of don't expect our hospitals to practice that quite
Well,
so expertly.
there are so many things that one discovers. Normally I would have discovered these things through clients or through research or whatever, but I had the minor misfortune. I had a minor health issue arise, and I had the good fortune from a clinical perspective, but misfortune of an encounter with a local hospital. And the hospital ended up overcharging me by about $1,000 because, as it turned out, I had met my deductible for the year. And so once the hospital was paid by the insurer, they owed me money back. And weeks went by and I got no money back. And I finally called the hospital, which I knew had been paid. And the hospital informed me that they retain all money paid by patients in the event that patients owe them other money, number one. And I said, but I don't owe you any other money. And they said, well, that's fine. No, we've checked you. You don't owe us any other money. But unless a patient asks for the money back, we don't send it back. You have to make a request. Now, as a very experienced insurance lawyer, I was able to put 2 and 2 together to know that my hospital had been paid in full, really, just about in full, and that I had been made to pay a cash deposit, and that I was entitled to most of that cash deposit back. I would guess that 99% of the American public doesn't know how to read a hospital's bill in relation to what an insurance company paid. And certainly nobody, including me, knew that if you're owed money back by a hospital, you must ask for it. And their rule of thumb, their default rule of thumb, is to hang on to money in the event that that patient, in fact, owes them other money. And then they feel completely at liberty to apply the balance toward other bills, even bills that might be in dispute. It's an astonishing thing. So, I mean, this is hidden 12 layers down. Now, of course, for your average poor person, they wouldn't have been able to put $1,000 on a credit card to get into the hospital to begin with. This was not an emergency admission. It was a scheduled admission. But it is so Byzantine. I know of no other business where if the business owes you money, you must ask the business, and the business pays you only if it determines in its discretion that it owes you money. Despite the evidence of, bills, payment history, etc. So I think we have not even begun to plumb the depths of hospital business practices and the difficulty of aligning something called the community benefit obligation with the business of running a hospital.
Yep.
Can I add
Well,
something
I think
to
we're,
that?
sorry, go ahead, Marty.
Oh, no, I just wanted to build on one point that Sarah made. If you are 52 years old and have breast cancer, try getting an appointment or an operation scheduled at one of these hospitals without the money and without insurance. Good luck.
Right.
Good luck. If you simply cannot afford it,
Right.
Good luck. In my opinion, charity care, in the true spirit of how America's hospitals were founded, if you go back and look at the philanthropists and churches that funded these hospitals and their charters, charity care is a priori saying, we understand you cannot afford, we are going to take care of you anyway. Not taking care of patients when they come in for urgent conditions as required by the EMTALA law, shaking them down for as much as you can get, and then writing off the rest as charity care. There could be a lot more a priori charity care among these hospitals.
Well, and just to reinforce that point, the whole structure of charity care assumes that a patient has received a service and is facing a bill. And Marty's point, of course, is that it is impossible. It's like something out of a Joseph Heller book. It's impossible to get the service in order to get the bill, because nobody will schedule the service with you. Most care is non-emergency care. And poor people just don't, if you're uninsured, they don't get non-emergency care. Really, in the end, financial assistance is about emergency care. And that's pretty much it.
Wow.
Yeah, and I can't resist. I mean, it is easy to get lost in the weeds here. It's easy to get lost in the Byzantine ways the money flows and the system operates, as you pointed out, Sarah. But I just sort of zoom back and just ask very high level questions. Why is there even charity care? I mean, why do we have a system in which there are people who simply have to think twice or three times and just may not even get the care? So that's obviously a whole bigger conversation. It has to do with a lot more, but I couldn't resist at least making that point.
Yeah,
Shannon.
absolutely. Thank you, Vikas, for making that. So we got interested in the question of whether there was variation in sort of how we calculated things based on sort of how much need there is in different communities and what the tax base is, what the tax requirements are, because it varies from city and state to city and state to state. They have different tax rates, and people who live in those cities and states have different needs for charity care. So, and both of those factors would affect a hospital's fair share as we calculated it. So we also compared hospitals within the same cities to kind of account for those factors. And it turns out there's still a lot of variation. We looked at Boston, where the Lown Institute is located, and given the estimated value of their tax exemptions, we'd expect Boston Medical Center to spend about $85 million a year on community benefit writ large, and Massachusetts General Hospital to spend $225 million on community investment and charity care. And this is based on what their revenue is. So here's what they actually spend. Boston Medical Center spent $96 million on charity care, a lot more than the 85, and on charity care and community investment, excuse me. And they spend double the amount that Mass General spent.
And, you know, this is really true in many cities. So if you go to New York, you know, two well-known hospitals had very different fair share spending. So New York Presbyterian has a very large tax break, estimated at about $350 million. Mount Sinai also has a big tax break, smaller than theirs, about $162 million. But when you look at both of those hospitals' spending on charity care and community investment, Mount Sinai actually exceeded the value of its tax exemption, whereas New York Presbyterian spent 111, which is a big number, but not close to what they would be expected to spend based on their tax exemption. So I know we're going to have questions, and I'm sure we'll get pushback. In putting our metric together, we made a deliberate decision to exclude three main IRS measures. One was Medicaid shortfall. Now, our view is that, you know, Medicaid pays for care, and the fact of the matter is that if hospitals' cost structures, which are really determined by their own operational decisions as well as the revenues they get from other sources, if those operations don't get covered by this cost, that's really not something local taxpayers should address. If it's a problem, it ought to be addressed, but not necessarily from local tax breaks. Sarah, what do you think? Does that make sense to you that we excluded this?
Well, Medicaid shortfall, of course, is an interesting issue. And as I noted before, it used to come up with Medicare as well. The Medicaid shortfall is sort of a euphemism for the difference between what a hospital reports its costs to be to the federal government and its total revenue from Medicaid. And the formula takes into account both payments for services as well as special supplemental payments that might be made to certain hospitals. If you're a hospital that is extremely Medicaid dependent, and you sort of account for that with your Medicaid as a percentage of your revenue measure, if you are a Medicaid dependent hospital, then it may make some sense, in my view, to allow some part of that quote unquote shortfall, which is really a discount. It's the discount you give, or you're made to give because that's what Medicaid rates are. it may make some sense to count that toward charity care, only because Medicaid revenue as a percentage of total revenue is so big. I prefer what you do. I prefer adjusting charity care obligations by the Medicaid dependency of hospitals, just like we adjust hospital payments under the disproportionate share hospital program by their Medicaid, the Medicaid participation rates. Certainly, if you are a large, powerful, high revenue generating hospital that shows significantly lower Medicaid patients than the population in your service area, both your immediate area and I would argue your service area for specialized services. If you show Medicaid patients well below their presence in the population, then I don't think it's justifiable to take a discount. The hospitals discount all the time. I mean, going back to my own example, the difference between what the hospital charged for the procedure I needed and what my insurer paid the hospital for the procedure I needed is just, eye-popping. And so discounts are part of the world. And there are certain kinds of hospitals that don't have any ability to cost shift. But then there are others that do. And I think in that case, certainly, Medicaid shortfall cannot be justified. And certainly for all hospitals, I would say we should move away from the discounting formula and instead think about the overall financial status of a hospital and its dependence on the program.
Yeah.
So before we go on, can I ask a question for clarity? Because you use this word cost shifting. And we also know that hospital charges to some degree are made up numbers. But in fact, hospitals do have, certain fixed costs. They pay certain amounts for labor in particular. They have to pay for devices, all this kind of stuff. But part of why hospitals have these costs is because of private insurance rates, which are quite a bit higher than Medicare most of the time and way higher than Medicaid.
Sure.
And so having this private insurance system in there, sort of jacking up prices for everything, is really part of the problem, isn't it?
Well, yeah, I mean, there are deeper issues. Obviously, this is a study about hospital behavior, but what you're saying is that the entire system of healthcare financing in America leads to all kinds of perverse behaviors that are not good for people. Somebody I noticed just raised a question, it's a good one, about whether hospitals that are Medicaid, highly Medicaid dependency, a lot of poor people, don't in fact get the benefit of what's known as the 340B drug program that lets them buy certain drugs at a low rate and then sell them to payers at a higher rate. And certainly for safety net programs, the benefit that you derive from the 340B discount is considerable. It's now changing all over the country, I might note. The benefit is going away. In fact, there's a case at the Supreme Court this upcoming term about whether CMS can take the financial advantage of 340B away from hospitals when calculating their Medicare rates. So that's one of these benefits that is maybe of increasingly limited value, but the fact that a hospital may be able to cut the magnitude of its financial dependence on low-income programs through 340B, I would guess does not begin to compensate that hospital for having a patient census that's 55 or 60% Medicaid. I mean, it's just such a huge census. And having virtually no privately insured patients and a lot of uninsured patients.
Thanks, Sarah. I really appreciate that.
Sarah, let me clarify something, which is I certainly don't believe that Medicaid shortfall isn't a thing for some hospitals.
Mhm.
Part of what we were trying to do here, and I think it's an important dimension to this conversation, is that the category of community benefit is kind of fuzzy
Yes.
and messy, and includes business operations issues, includes financing issues, includes all these different pieces. And our view is that let's really try to talk about what is truly community benefit. Let's identify it. Maybe let's clean this up a little bit.
Well, you're totally correct, because really, in the end, the reason to give a hospital the benefit of Medicaid shortfall is to cushion its own financial situation. It's not, I mean, it's not an inducement to take Medicaid per se, because if you're Elmhurst Hospital, unless you want to shut your doors, you're participating in the Medicaid program. And in fairness, of course, Columbia Presbyterian and Langone and all these hospitals undeniably participate in Medicaid, although I should be clear, that doesn't mean their affiliated physicians do. That's a
Yep.
huge difference.
Yep.
Yep.
And the hospital may stand there with an accessible emergency department, and its advanced oncology program may be totally inaccessible because none of its oncologists participates in the Medicaid program. So not to overstate the problem, but to get back to your core point, I think there are better measures than discounts. And I think the better measure is just what is done for DISH, which is your dependence. You know, how sensitive are you to Medicaid revenue coming in? And if you're one of those hospitals, if you're a deemed DISH hospital, then, you know, we need to do everything we can to financially support you, which doesn't diminish the fact that you need to support your community. It's really sort of two different obligations.
Yep. Yep. We also didn't include hospitals' unreimbursed costs for training clinicians and for doing research. This obviously has a big impact on academic medical centers and their performance on our community benefit index. Our view was that neither of these buckets really tends to be based specifically and directly on local community needs. Now, Marty, you already talked about physician training programs and some of the economic role they may play. You know, those training programs reflect a lot of different factors, but I'd say the needs of the local community is generally the least of these. So that was a reason we didn't incorporate that. And while we may need to subsidize training for doctors, the question of how and why and by whom, I think, is something that is, as we were just saying, an important question to clarify. Sarah, any thoughts on that?
No, I mean, I would have the same reaction. Marty, I'm curious. I mean, you are of this world, but to me, unless there's some really direct link between the training program and the care that's going on for the population that is the most in need of what we call a community benefit. If you are training, you know, on oncology residents in an advanced practice where none of the attending physicians and the program generally really does very little in the way of caring for, as Marty pointed out, scheduled uninsured patients, there's no Medicaid participation, I fail to see the connection back to the community.
Research funding is interesting because there's so much cost shift accounting with research dollars at large institutions. It's hard to have any real sense as to whether or not ultimately it's a money gainer or money loser. If I get a grant for $1 million from the NIH, the institution might get $500,000 directly deposited into their bank account on top of the $1 million that I would have for the research study. That's a lot of money, especially when you're talking about the type of research I do, which is similar to the research Sarah does, and that's public policy and data research, that we don't have $500,000 worth of laboratory or real estate costs, and the costs in real estate in Baltimore might be some of the cheapest in the country. So we don't have a good sense of it, but here is the ultimate indicator. The second Congress talks about cutting the indirects or cutting NIH dollars, the academic leaders of medical centers immediately rush to Capitol Hill, begging them for more money. So that to me is an indicator that research funding is profitable.
Well, Marty, I mean, I would jump in and say, I wouldn't be opposed to expanding NIH funding. I think that's the right way to fund research. But at the end of the day, the question I have is that medical research or the dollars that are reported to the IRS as a community benefit and therefore justifying a tax break, are those dollars in any direct way reflecting the needs of the local community? Is the research focused on the local community? Or does the local community have any provision to participate in the input on the priority setting?
Well, but those are two questions, because one of the questions is the hospital spending its own money on the research? That's the money they're supposed to be reporting for their research break, for tax breaks, isn't it? It's not the money they get from the NIH.
Right. I mean, likely it's going to be a mixture, and likely different hospitals will have different practices in that regard. But I mean, I maintain unless we're going to let local community groups and boards, either review the research or approve it, or perhaps participate in the intellectual property that might emerge from it, it's not really justified as a local community tax break. What do you think?
Well, I should note, a few years ago, actually, there was a change in IRS policy because, in fact, research funding from the federal government was, if I'm not mistaken, it's what community benefit reports is your expenditures, not necessarily your expenditures of your own money. So if they were spending research funds, it was an expenditure.
That's double dipping.
Well, and that was the argument in the end that the IRS made. But there was actually some controversy around how to treat research expenditures in relation to community benefit spending. And so it just sort of adds to the curiosity of this whole question. I mean, does the fact that here in Northern Virginia, where I live, we have a massive health system that has amassed a huge amount of working capital to spend money on a state-of-the-art cancer treatment program for Northern Virginia. And I am sure a portion of that is claimed as a community benefit investment. And my guess would be, I mean, it makes the community a more attractive place for certain people to live in. Whether it benefits the community the way we think of community. I mean, that's the implicit issue in this whole presentation, is when we talk about benefiting a community, we don't necessarily mean the panache that having a world-class cancer center brings to Northern Virginia. We are talking about something much more immediate and measurable in terms of inequality of access to care. Mm-hmm. But hospitals would say, look, we serve the entire community, and so it's a good thing for us to be strong and vibrant and paragons of training and skilled care. But I think the bigger question is that, of course it is, and there are many reasons to be that way, but do we spend our tax dollars on that? Do we give a tax benefit for something that, remember, began life as an emergency department open to everybody and charity care for people who couldn't pay? That was the roots of community benefit. It was very much tethered to the people who could not get access to care if the hospital didn't help them in some way. And so this notion that, any benefit you bring to the broader community as a whole should be tax deductible or give you tax exempt status is, I think, the question on the table, not whether they are good things for your community. Of course, they're good things for the community.
Right. Yeah, I agree completely. So we have a ton of questions from the audience. We'll try to get through as many of them as we can. And then we'll move on. So one question, is there a standard way in which a specific community benefit is actually valued? For example, health fairs. The questioner said that, she has heard in the past about street fairs or fairs that are held with private companies that are often recruitment tools or marketing tools, like that a hospital could distribute souvenirs such as pens, scratch pads, mugs, value them unreasonably, and then claim all those expenses as a community benefit. So is there a standard for valuing these things?
Well, I can give a little hint of values, and there are obviously there's going to be differences, but at one point I was writing about PSA testing, prostate specific antigen testing, and a hospital marketing department told me that they did free PSA testing because a certain number of men would come up with a high PSA and the hospital would then offer them a free biopsy. And a certain number of those men would then come up with what looked like an operable cancer, and then they would get a surgery, which would not be free. And the marketing department was very open about the fact that they in fact netted positive revenue from giving those free PSA tests. And they said, even better, it brought the wives in for their mammograms, et cetera, et cetera. So there's a certain amount of sort of lost leader work there. And maybe the health fair might have a mix of value to the hospital and then value to the community.
I think that's right. And I think that, it's very hard to think of activities that are so pure that there's not a spillover effect. And the IRS does have rules. There is the Schedule H is not just a list of things. It's Boku instructions about what goes where on what line. And the IRS makes the point that if this is being done primarily for marketing purposes, you can't claim it as a community benefit. The fact that some people's cancers are found, and I have very different feelings if it's a Medicaid expansion state, because if it's a Medicaid expansion state, then with limited exceptions for people who are not legally present in the US, which of course is one of our number one problems, what we don't do for people who are not legally present in the US. But in, say, New York or Massachusetts, it's very hard to find somebody, particularly among the Medicaid eligible population, because they can enroll at any time, who can't get coverage for the treatment. It's another thing to be doing these tests in Texas, where you're looking for the odd person who didn't realize he had prostate cancer, perhaps because there is no insurance. Unless the person happens to qualify for marketplace subsidy and it's an open enrollment period, there's no Medicaid for poor people. A poor man, say 63 years old, who gets a screen and is told, it looks like you have prostate cancer. So context is everything here, but I would say free screening activities in a state where we've dealt with the insurance needs of people is very different contextually from a state where it's hopeless, where one could argue ethically there's no point in knowing your status because because there's nothing you will do about it.
Yep. So a couple other questions. There's one asking whether we found a correlation between community benefit spending and hospital consolidation, and in particular whether some small city nonprofit gets taken over by a big city nonprofit. And it's an easy question to answer because we haven't had a chance to look at that. It is definitely an important question to ask. It's the kind of question that probably the IRS or maybe Congress could or should ask. It's certainly something that if we had the time and resources, we would be interested in looking at, but we haven't done that yet.
Well, and one of the other problems, of course, is that unlike the community health needs assessment under the ACA, community benefit spending can be reported only organizationally.
Yeah.
And so and one of the recommendations we have made is to require that all community benefit spending be reported by facility.
Yes.
That even in a multi-facility organization, so that you can see what happens to facilities as they move through commercial space.
Yep. And that relates to another question, which was, did the team consider systemness when we completed the analysis? Because many integrated systems provide community benefit either at the individual facility or at the high level in aggregate, or both? And the answer is we're aware of that, and we used a prorating method as best we could to try to capture each individual facility. But as Sarah just said, it would be infinitely better if we had reporting directly at the facility level. And I think it would be better for transparency. It probably would be better in terms of matching community needs more directly and comparing those. Because at a system level, the geographic spread and the socioeconomic spread may be so vast that a community needs assessment matched to community spending is probably really difficult to make sense of. So somebody asked, what about community health needs assessments? And I guess I'll fill in what about them. Where do we stand with that? I thought the ACA had required that there be those. And while they may exist, I don't believe there is yet any actual either enforcement or accountability of matching the needs assessment to the actual spend. And that'll have to be the last question because we got to move on. Any thoughts, Sarah, you know?
Well, in fact, there is no link in the law between the needs assessment and the implementation strategy, which is supposed to explain how you're going to go about carrying out the needs assessment. You don't even have to make the implementation strategy public. Many hospitals do, but others might not. And there is no requirement that your community benefit spending mirror the priorities established in the needs assessment, which is another recommendation we've made.
Well, that's a great answer because it's actually an immediate segue into what we want to talk about next, which is really what are we going to do? What needs to be done? What can change this the situation so that hospitals really are stepping up to their obligations, what communities expect them to do, as well as what the IRS expects them to do. So how do we hold them accountable? Sarah, you've just spoken to a couple of changes in the IRS regs. Who should be responsible for enforcement? I mean, I love that Marty's comment about sort of transparency having a really important role in terms of communities seeing and patients seeing what's going on. But who's really in the end responsible for making sure hospitals are doing what they're supposed to be doing? And I'd love both of you to answer that question.
Well, I mean, legally, the IRS, Treasury,
but they don't do anything.
It's interesting because you're, of course, in Massachusetts, and the Massachusetts Attorney General has been quite active around this issue, and of course has built out other obligations of hospitals, including being responsive to the state's own health planning priorities. So Massachusetts stands there as an example, as does Oregon. There's been a lot of activity in Oregon, examples of states where the state health care authority or attorney general's office, it can vary depending on the state, embraces this issue. And of course, there is no reason why a state agency cannot enforce state and federal law. It's certainly when a state scrutinizes behavior, local behavior, it's also scrutinizing that behavior under the Internal Revenue Code. So and you're absolutely right. I mean, I think for the IRS, more aggressive enforcement is an important thing around particularly the issues that Marty researches, which is billing and collections. I mean, that's the one where there is clear evidence, okay, of hospitals continuing to use unreasonable collection practices, continuing to send bills that have not been adjusted. I mean, all the things that are just so overt and so immediately harmful to immediate people as to merit the highest level of attention. As far as sort of the broader issues we're talking about, what priorities hospitals are placing on their need communities, not necessarily the whole community, but the community that essentially justifies their tax exemption. I don't think it's I don't think it's any one agency. The IRS certainly can say you did or did not turn in certain documents. They can, where it would be helpful is to redefine some of the community benefit policies they have today. But in terms of enforcing those policies, I think it's really on communities to understand the policies, and through the community health needs assessment process and the implementation process, demand an accounting for community benefit. Which they can do. They can say, we want to see how your community benefit spending matches up against all these, this list of 10 priorities here.
Yeah.
Actually, I want to just put in one plug. I think the NIH has a job here and a role here. So the NIH does not give hospitals money that if they are not certified, in effect, to be able to do research because they violated some research standard. And when you claim research tax breaks in a way that is not completely above board, in a way the NIH could be a very powerful motivator for hospitals to really shape up and do the right thing, for at least for the research hospitals. Anyway, that's just a little plug for all federal agencies that have anything to do with hospitals having some role here, not just the IRS.
Yeah. Marty, you told us that, just shining a light on billing practices can sometimes lead to significant changes in behavior. And I believe that. I think in these huge, complex institutions, sometimes the billing practices may come as a complete surprise to the C-suite. So to what extent, you had some challenges in gathering this data. So I'm curious, given those data challenges, whether you think there are any other avenues or ways we might be able to promote the accountability, specifically around billing quality, because it's a clear and recurring issue.
Good point, Vikas. So it's amazing. We spend $3.5 trillion on healthcare, but we spend probably less than $100 on measuring the billing quality metrics of a hospital, right? It's basically up to a couple local individuals to figure out what's happening, maybe contact a local journalist, and that we should do that. We need an all of the above approach. One, engaging with the media. We've seen a tremendous amount of impact from Kaiser Health News putting pressure on UVA, for example. And my team also called the donors to the hospital and told them, hey, do you know this is what this hospital is doing? That had an impact. Guess who is on the hospital board? The local banker is on the board, local business people, community members, philanthropists. They often have no idea what's happening. So as we all bring this to the attention of the hospitals, as we physicians protest predatory billing, saying, hey, these are our services that you're shaking our patients down for. We are, this is wrong. And we saw that happen at some hospitals. Also, I think when now we're trying to engage with big tech, who I have a mixed relationship with, but we're trying to tell them, hey, when somebody Googles the name of a hospital, don't just put the name and the address and phone number of the hospital, put the name and the address and phone number and their average billing quality score and their price markup. That is, what is the cash price if you go in and say, I'm going to pay in cash above the Medicare allowable amount. This is how we're going to create more accountability. Billing quality is medical quality, and financial toxicity is a complication. And just like we measure other complications in your field of cardiology, Vikas, or my field of surgical care, we can also measure billing complications. And I think that'll help reward the good actors in the market.
Thanks.
But couldn't we use some sort of central database to be able to do that?
Yeah, it's amazing.
Wow.
How much money do we spend on other databases? Well, we can sequence the whole human genome in 45 minutes when you walk in. Or right now, when somebody says, hey, we've got 2 hospital systems in town, which one has the 11 times markup and which has the 2 times markup, which is the Mount Sinai data that you showed and which is the New York Presbyterian data that you showed. This is stuff that we can bring to the public light.
All right, well, we have a lot more questions, so let's get to it. The first one, are there any regulations or accountability measures that actually ensure that the community benefit activities are effective?
Nope.
No, and I don't know that you could regulate effectiveness per se. You could regulate transparency, you could regulate accountability, you certainly could regulate a more rigorous definition of what we recognize as a community benefit activity, to zero in on certain parts of the community. And in fairness, the IRS rules implementing the ACA amendments make clear that in doing community health needs assessments, the hospital is expected to zero in on that part of the community that has essentially is the most at risk for being excluded from healthcare. So the medically underserved parts of its community, but it's hard to imagine a rule that regulates the effectiveness, the outcome of the investment itself.
Another question, could we talk about the pros and cons of pilot, P-I-L-O-T, programs, which stands for payment in lieu of taxes? Either of you have a thought on that?
Maybe it's Sarah's better in a better situation to comment on that. But I will say that hospital consolidation is one of the greatest threats right now to a lot of transparency work, because when you can have transparency of prices, but when you only have one health system in an entire region of a state, they might just say, take it or leave it. And then all of a sudden, monopoly pricing starts to dominate.
Well, yeah, I would just have, that's totally true. I mean, that the underlying issue is not the payment. The issue is its total impact on the price of healthcare. But also, certainly getting a hospital to make payments to replace the money that has been lost to the system because of its tax exemption is really important, except to the extent that the payment is seen as a justification for not providing community benefit. I mean, community benefit, from my perspective, ought to be tied to Medicare conditions of participation, to licensure as a hospital. We have tied it to tax exemption, which has sort of an ineffable meaning anyway, and then we leave out a lot of hospitals, of course. So I think but it goes to sort of what is your vision for the healthcare system? And to me, the healthcare system is there to bring a benefit to the community, and it may vary depending on the kind of hospital and where it's located, but every hospital should have an expectation that it'll bring community benefit.
Got it. Here's a question. What might compel some of these large, very prestigious institutions to become anchor institutions? And I'm going to read between the lines, because I think, anchor institution can mean many things, but in this instance, I think what's meant here is institutions that through their hiring practices and their business practices in general, make a concerted effort to be much more involved directly in their local and surrounding communities.
I mean, I'll say that one achievable goal that we can set is for hospitals to disclose and set priorities in terms of the amount of care that they deliver for free a priori before the person receives that care. In other words, imagine if a hospital said, we have a budget for charity care, and so 100 operations a year of this caliber operation, we're going to perform as a community benefit for people who cannot afford the operation. And we're going to let them know before the operation. So when they, we have these hard conversations that you have cancer and they say, I don't have any insurance and we don't have much money. We say, well, go talk to our financial aid person. right now that conversation is basically, we can't schedule you unless you put a down payment down, or, you show us proof of insurance, or maybe we can retro enroll you in a Medicaid program, which sometimes hospitals have no interest in doing that. Setting aside a benefit that could be delineated before that care is rendered would be something that's very achievable for most hospitals.
Great. So here's an interesting question, a little more theoretical. Is the core issue here how we define community benefit? Or is the core issue what constitutes a nonprofit hospital? And maybe we're too much in the weeds trying to figure out community benefit when we ought to be really trying to understand what is the meaning of a nonprofit hospital. Thoughts on that?
Well, I don't know. I'm sure I'm not the only one on this on this session who remembers the unbelievable debate that went on for a long time between Arnold Relman and Uwe Reinhardt about the whole concept of whether behavior by nonprofit hospitals, and I assume what you really mean is tax exempt hospitals.
Right,
it's actually two different things. Uwe Reinhardt's position was that this whole area is ridiculous. Hospitals should be expected to do good. They should be expected to make contributions to society, no matter what their taxable status. And of course, if you teach health law like I do, you spend your whole life teaching tax law in hospitals and what's related business and related income and unrelated income, and all the ways in which hospitals can maintain their nonprofit status or their tax exempt status and still engage in huge money-making operations. And you walk away from this area of the law sort of scratching your head as to, what exactly tax exempt status is all about here. Arnold Relman argued that there are still things about there's sort of this ineffable quality in tax exempt hospitals. He's, what he would think today, I don't know. I think it's one of those sad aspects of social welfare policy in the United States that what it tells you is we still think of healthcare as beneficence. I mean, that's the meaning of community benefit or tax exempt.
When in fact,
that's right.
It's a little bit of beneficence and a whole lot of money making, isn't it? Often.
To the extent that there may be many of us on this call who really do not think of healthcare as a beneficent activity, not at the level of financing and delivery, the big issues. There obviously are individual providers that do beneficent things, but at a social welfare level, the notion that we would finance healthcare through beneficence is a sad commentary on how far we have not come.
Marty, you used, oh, sorry, go ahead, Vikas.
Well, I was just going to react and say, in some ways that whole dichotomy is more and more obsolete. I mean, we have another metric, which we're not talking about today and probably won't have a special session on, but we're looking at pay equity. And the story of C-suite compensation in the hospital sector, including the nonprofit sector, over the last 20 years is really a story of convergence with the, for-profit world. Yes, they still don't make as much, but the culture, the sort of attitude, the mindset, all of that has drifted in that direction. So I think it's a great question what Bud Relman would think today. Of
the medical industrial complex.
The medical industrial complex. But really, I do think that if we're going to think of healthcare as a public good, it really is hard to make sense of this kind of moth-eaten mosaic of for-profits, nonprofits, some are one or the other in drag, and then there's public and, all this stuff. When what we really need is sort of much greater uniformity, greater sense of the public good as actually being met, and much greater accountability. So that's a long conversation, there was another question, what's the Lown Institute's theory of change on this question? And I don't have another 5 hours. Like, I'm not going to take up time on that one right now, but it is a core question. There is one other sort of high-level question that I'd like to pose from the audience, which is, what are your thoughts about the current political climate to address these issues? What are the opportunities? And maybe I should say, and particularly, what are the barriers? If you're optimistic for the current period, what are the barriers?
Marty, why don't you grab that one?
Well, I do think the climate right now is ripe for driving some of this change. We're seeing more interest in this than we've ever seen before. What was relegated to sort of academic discussions and health economics and at the Lown Institute and on our research teams that, for all of us that have worked on this, is now center stage in America. I think enough people have been affected. Members of Congress are getting an earful. People are crying, unjust practices are happening to them all over the place. So I think this is a good time. And I think it's also encouraging to see a lot of bipartisanship here. This is really not a, red-blue issue. This is an issue that's affecting most Americans, or almost every American through their wages, versus a large special interest where you even have a trade association acting as, I would even say, disproportionate to their members, which is common among trade associations. But I can just tell you that because I've talked to numerous hospital leaders around the country that say, Marty, I can't say anything publicly because our hospital association is suing your price transparency executive order to undo it, but keep going. This is a fight we need to win on the side of transparency, and people against it are on the wrong side of history. We've never seen that kind of bipartisanship, and Javier Becerra doing some more steps forward here in the recent month. I think probably Sarah's working behind the scenes getting some of these things advanced, but we're seeing now some promising signs we have not seen in a long time.
What are the barriers, Marty, still?
Well, I think the special interest, right? We've got basically a lobby group at every state level. It's incredibly well funded, maybe the most funded of any lobby group at that state. And they wait around for anything that could threaten hospital revenue by $1. I think the way around that is the transparency of the metrics, what Lown is doing, what we tried to do with the Axios report, which grafted in the Lown Charity Care score. And eventually, I think we'll get a 5-star billing quality score for healthcare that will be attributed to every hospital. And the hospitals that do poorly will be the hospitals patients want to avoid.
Sarah, your thoughts on the current political climate?
Yeah, this is one of these issues where you sort of think, at least I think, at two levels. At the level of legislative reform, I think that there has been congressional interest, once again, as Marty says, in the amount of money that's being expended on tax-exempt hospitals, and questions about whether that kind of expenditure represents the best use of the money, and not, I don't get any sense at all of an interest in foreclosing tax exemption. But I do receive questions about what changes ought to be made in the 2010 reforms. And interestingly, in this sort of associated world of community benefit, which kind of runs alongside the 2010 reforms, the interesting thing is that the line, the dots that should be connected between what a hospital is planning for its community and how it's involving its community in planning, and how it's identifying priorities for community health improvement, and all these things. There's no connection between that and the community benefit spending. Literally, as a matter of law, there's no connection. And so the question is, should there be a connection, number one? Number two, what ought to count as a community benefit? If we're really interested in that part of the community that's most likely to experience health inequity, then that argues for a tightening of the definition of community benefit and a tightening of the relationship between community health improvement and community benefit. And if we're interested in transparency, as Marty's work shows, and as your work, certainly underscores, then we should certainly require that community benefit spending be reported at the facility level, because it is increasingly not possible for communities to know what their hospital is spending on them. If you can amass all this information at the organizational level, and your organization consists of 240 facilities, and what you have is this enormous community benefit war chest that you get to, do good works with, but in a very removed way from the communities that the facilities are designed to serve. I think that's just basically unfair.
Mm-hmm.
Yep. Well, we are completely out of time. In fact, we are over time. So I want to thank our guests, and I want to thank everyone who joined. Let me just say, for the Lown Institute, we do think this is a moment that has a lot of possibility. There's absolutely no question that the COVID pandemic has opened a lot of eyes, and we do believe that transparency and the kind of work we're doing will help move the ball forward. So thank you for joining us. We look forward to seeing you again in the early fall, when we'll release our full rankings for 2021. Thank you.
Thank you.